Good morning, everyone. I'm Dr. Srinivas from the Department of Pediatric Gastroenterology. Today, we'll be presenting our topic, ingestion of unusual substances by children. So unusual substances, they can include drugs, foreign bodies, corrosives. They can include cosmetic materials. And these substances have also been found to be the most common unusual substances ingested by patients in US. So coming to the Indian scenario, we do not have accurate data, but we found that foreign bodies and acute corrosives are most commonly ingested, and hence we will be stressing on these two substances. So the overview of our presentation, we will first speak about foreign body ingestion, followed by acute corrosives. We'll give a departmental data and present a few cases that we have managed. So as per the statistics of the United States of America, foreign body ingestion is the fourth most common unusual substance exposure in children. And this is a preventable cause of morbidity and mortality. And this foreign body, it can be very notorious because serious complications can develop within a very short interval of time. Over time, the trend of foreign body ingestions has been increasing. And as we can see in 1995, the foreign body ingestion used to be around 9 per 10,000 children, whereas it has increased to 17.9 per 10,000 children in 2015. So over time, the number of foreign body ingestions have been increasing, and also the more riskier foreign bodies such as magnets and button batteries, they have been increasing in number. In COVID era, we would have suspected that like with any other disease, the foreign body injections might decrease, but they have not decreased. We have found that the number of coins ingested decreased. That is likely due to the change in the currency from notes to coins and use of digital currency. But the more serious substances such as magnets and button batteries, they have increased in quantity. So the foreign bodies, once they are ingested, they get stuck up in multiple areas of a gastrointestinal tract. This is because there are areas of anatomical narrowing in the esophagus, the pylorus of the stomach, the C loop of the duodenum, as well as the ileocecal junction. So they can get stuck up anywhere over here. And this is likely to occur, especially when the diameter of the foreign body is more than 2.5 centimeter, or when the length of the foreign body is greater than 5 centimeter. The different type of foreign bodies that we can see here. So this is the magnet. Sorry, this is the button battery. These are stack of magnets, sharp objects, and these are super absorbent objects. They are made of polymers, which when come in contact with water, they increase massively in size. So they can cause obstruction of the gastrointestinal tract by increasing in size. Management of foreign bodies will be in terms of their removal. So we would prefer an endoscopic removal, and if it fails, to go for a surgical removal. The other part would be if the foreign bodies are not very big, or if they're not causing any harm, we can follow a wait and watch approach. Timing of endoscopic removal will be broadly into three categories, that is emergent, urgent, and elective. So emergent, we remove it within 2 hours, urgent within 24 hours of presentation, and elective after 24 hours of presentation. So this timing will depend on the type of foreign body, the location of foreign body, the size of the foreign body, and the symptoms that the patient has. Now, emergent removal will be done in any symptomatic patient with a foreign body, and otherwise, even if asymptomatic, button batteries and sharps which are present in the esophagus will be removed on an emergent basis. Urgent removal will be done for all asymptomatic foreign bodies which are present in the esophagus, or in case of button batteries which are present in the stomach. And an elective removal will be done for other asymptomatic foreign bodies which are present in the stomach or B1. So coming to the spectrum of foreign body ingestion worldwide. So as we can see here, studies from Germany, Taiwan, USA, and South Africa, they have all shown that the predominant age group of presentation will be around 6 months to 3 years. And more than 75% of the children less than 6 years are the ones who ingest foreign bodies. So beyond that, they have an idea as to what to be eaten and what not, so they are less likely to present. However, if there are comorbidities such as a strictured esophagus, or if there is an underlying intellectual disability or a delayed development, they can be ingesting foreign bodies. Coins were found to be the most common objects, and they are found mostly in the esophagus or in the stomach, and around half the patients were symptomatic. Whereas the spectrum from India, again, we have a similar picture, the similar age group, coins again being the most common. However, this study from Srinagar had shown that there were more females involved, and sharp objects were found to be more common, that is 69%. The most common sharp object that they have removed was the scarf pin. So likely because of that particular area and the style of clothing dictated this presentation. Now, each foreign body has a different mechanism of injury. So sharp objects will pierce the intestinal wall and they will cause injury. Blunt objects such as coins and all, they present with pressure necrosis. Coming to the most dangerous button battery, so this gets lodged. It causes most of its symptom when it gets lodged in the esophagus. So as we can see, it is lodged between the two walls of the esophagus, and it results in the formation of a continuous circuit. So there will be passage of electricity from the positive to the negative terminal, and thus causing electric injury. Also, the other thing with the passage of electricity, there will be ionization of the water molecules in the mucosa, resulting in hydroxyl ion generation. So that will cause caustic injury. And as with other objects such as coins, it can also cause a pressure necrosis. So because it has three different mechanisms of injury, it is likely to cause more problem when compared to other foreign bodies. Now coming to magnets. When a single magnet is ingested, it behaves like any other foreign body, and it can cause damage like that of others. But when multiple magnets are ingested, these multiple magnets can be present in different parts of the bowel loops, and they get attracted towards each other. In doing so, the wall in between, it undergoes a severe pressure necrosis, and that can result in bowel perforation or enteroenteric fistula development. So as we can see the operative specimen over here, the two bowel loops, they have got attracted to each other because of magnets in them. And this has resulted in a perforation. And here we can see that the magnets are being removed. The problem with magnet ingestion is multiple magnets may not always be easy to identify on X-ray. As we can see over here, this is a patient with multiple magnet ingestion, but it appears like a single foreign body because this is a stack of magnets. So a high index of suspicion must exist when magnets are ingested. Most of the time with magnets, it results in an endoscopic or surgical removal being needed. Coming to our departmental data from 2012 to 2022, from when we have maintained our own endoscopic records, we have had 102 foreign body patients with foreign body ingestions that have required endoscopic removal. The mean age of our presentation was found to be around 45 months, that is around 3.5 years. And the range of presentation has been from as low as 4 months to 192 months. And our patients have presented to us around 24 hours after the foreign body ingestion, but some have presented as late as even 2 months. We were able to successfully remove the foreign body in 97% of our cases. And around 60% of our patients were asymptomatic. So we had 42 children who had a normal anatomy, normal esophagus, and we had 60 children who had a strictured esophagus. And the common foreign bodies that we have removed endoscopically were coins, followed by button batteries and plastic objects. And they were commonly located in the esophagus or in the stomach of the child. And uncommonly, we have even found them in the duodenum and in the cricopharynx. So among patients who had a strictured esophagus, we found that 78% of them had food bolus impaction in them. So now I would like to invite Dr. Sneha to continue our presentation in terms of button battery and show a few cases that we have managed.
Thank you. Good morning, everyone. I'm Sneha, and I will be sharing with you our experience with button battery ingestion in children. So, the common sources of button batteries include toys, hearing aids, flashlights, and other electronic devices. And severe injury can occur with exposure time as little as 2 hours. And complications occur mainly when the button battery is lodged in the esophagus due to its proximity to trachea and aorta. And the complications range from perforation, stricture development to fistula formation, which involves the tracheoesophageal fistula and aortoesophageal fistula. And many case series have reported stricture development in up to 5 to 40% of the cases. So, coming to our first case of a 1-year-old girl who presented with vomiting and dysphagia for 10 hours. An X-ray was obtained outside, which showed a foreign body impacted at the upper esophagus, likely a button battery. So outside, endoscopic removal was attempted. However, as the foreign body was impacted in the mucosa, it could not be removed. So within 12 hours of ingestion, this child was referred to us and we did an upper GI endoscopy. As you can see on this endoscopic image, this is the button battery, which is impacted in the plecopharynx. This was removed with a rat tooth forceps. And after retrieval, we can see that this area of impaction is showing extensive ulceration. However, no apparent fistula or perforation could be visualized. So we did a repeat endoscopy after 3 weeks, which is showing normal mucosal healing of the esophagus. So coming to this question, that how can we identify button batteries on chest X-ray? So here I've put on 2 images comparing the button battery with the coin. So in the AP view, we can see one rim around the button battery, which is known as the halo sign. And similarly, for the lateral view, we have a step-off sign for the button battery, and this lower end represents the anode of the button battery. So coming to our next case of a 3-year-old boy who presented with complaint of cough and dysphagia for 2 months. A chest X-ray was done, which showed a foreign body with the characteristic step-off sign in the esophagus. So this child was sent to us 2 months after suspected ingestion. So we did an endoscopy. This is the endoscopic image, which is showing the button battery, which is deeply embedded in the mucosa of the esophagus. And we have retrieved this with the rat tooth forceps. I'll be showing you the video. So this is the button battery, which you can see is embedded in the esophageal mucosa, and lower down, this is the esophageal lumen. So yes, this is the rat tooth forceps, with which we are trying to get, and we have caught hold of it, and now it's being retrieved. So after removal, after 3 weeks, we did the repeat upper GI endoscopy, which showed a narrowed esophageal lumen. And also there was a formation of a diverticulum. So we did a barium swallow X-ray, which showed a stricture at the esophagus. As the child developed the esophageal stricture at the site of infection, he underwent serial endoscopic dilatation sessions, and currently this child is doing well. This brings us on to one of the most dreaded complications after button battery ingestion, that is the aortoesophageal fistula formation. So the SGPGIMS 2021 guidelines recommend that a contrast CT or MR of the thorax and neck should be obtained if the time of presentation is more than 12 hours after ingestion of the button battery, or if severe symptoms like bleeding, hematomesis, back and chest pain are present, if the patient presents earlier than 12 hours. So on the cross-sectional imaging, if the distance between the inflamed esophagus and the aorta is less than 3 millimeter, it is better that we consider for the removal of the button battery at the cardiac catheterization lab with the support of an intervention cardiologist and a cardiothoracic surgeon. And management is mainly surgical. So 2 large systematic reviews show that complications, that is these vascular complications, occur in 6% and 14% of the total cases of button battery ingestion, out of which 80% were fatal.